Any questions from audience?
Yeah, till the question comes, one question, Dr. Suresh. Yeah, you said ketamine is not so detrimental in elderly. Can you just slightly continue? Because we always believe that ketamine is more avoidable in all age groups, especially except a pediatric age group, especially females, adults, and elderly. These are the things we say that ketamine to be avoided or something like that. So would you just elaborate on that?
Yeah.
You can
Actually, you know what, in the past, we used to have, a lot of debate regarding ketamine when it comes to your post-operative cognitive dysfunction and then, delirium. So all that we understood from the recent literature is it does not have any effect, neither benefit nor harm. So, and a lot of studies have been done in the recent past with regard to subanesthetic doses of ketamine. And they all, quote that, this is very good, because it does have, better hemodynamics. And then the other aspect is you don't have to really worry about delirium aspect at all. And if at all, there will be a little bit increase in heart rate, bit increase in blood pressure, which will not really affect. The other important thing is you got to be more worried about contraindications, especially when you're talking about severe valvular heart disease or decompensated kind of heart failure, where you'll have to be really worried about ketamine, where you'll have to make sure that this is avoided. But for that, if you don't have such issues, you can still go with ketamine. It's not a bad choice.
Is that the hypnotic dosage you're talking about, or is that an induction dosage you're talking about?
I mean, see, as we all know that, in the elderly, we actually rule them out of, most of our studies, because there are positive of studies when it comes to elderly kind of patients or pregnant ladies, children, all that. But then what they say is definitely is, in subanesthetic doses, that is what the recommendation is. And, obviously, if the patient does not have any contraindications, subanesthetic doses are something which are very good. And then it's been used both in ICUs and, in the perioperative period as well. And it is quite safe in elderly.
So to Dr. Suvajit, sir, so you said TIVA was preferred, but can we use inhalational agents during one lung ventilation?
Yes, surely. So to use TIVA, you should be a little bit experienced for using your TIVA or TCI. So your plasma concentration has to be enough so that if you are using solely as a sole anesthetic agent. But the newer inhalation agents like your isoflurane, desflurane, and sevoflurane, if you use less than 1 Mach, so there is no harm. It will not hamper much in your hypoxic pulmonary vasoconstriction. So you can use your inhalation agent. But in your setup, if you have TCI pumps and you know how to use TIVA, I think you can go with the TIVA also.
Okay, thank you.
Hello, Pudar. Yeah, one more. Regarding lung recruitment strategies in one lung ventilation.
So for the non-dependent lung, we can use CPAP bags. CPAP bags can be adjusted to your auxiliary oxygen port, and with a 2 centimeter to 3 centimeter water, you can give recruitment to your non-dependent. Now coming to the dependent lung, which is our ventilated lung. So in that case, you can take the APL valve to around 20 centimeter of water, and you can put recruitment for 20 seconds. So it is also called 20:20. So you close the valve to 20 centimeter of water for 20 seconds, and then you can continue it till you improve the oxygenation.
No, but there are few proponents who want the airway pressure to be very, very high. They take up to about 30-35 for lung recruitment. Is it recommended?
So, yeah, like if you increase more, there's a higher chance that you can go for your volutrauma or atelectatic trauma. So, till 30 centimeter water, it is preferred, but not more than that.
Invariably, whenever there is hypoxia, you go for a manual ventilation.
Sorry, sir?
Whenever there is a hypoxia, So we turn on to the manual ventilation. Is it suggested, or whether you can continue with the mechanical ventilation?
No, it is always prefer if you go for your mechanically ventilating with your hand, you are saying?
Yeah.
No, I think it's much better. Your pressure will be maintained. You can give your desired tidal volume. So it is always better not to mechanically ventilate your lungs. So it's better is you can go with your normal anesthesia machine.
You didn't get. Whenever there is hypoxia, invariably in the stress or something, we shift to the manual ventilation.
It is our body's response.
Yeah, but what is the response to take to the,
As if we are thinking that we are going to put a pressure and increase the oxygenation.
Yeah, that is an invariable response from the
response
from the anesthetist, whether it is advisable or not. Because whenever you take in the manual ventilation, the pressures you cannot keep down the 30.
But yeah, like you can go till 20 centimeter. This at least you can give some recruitment maneuvers for 20 seconds. So at least you can give till 20. Let's not just go directly with 30 centimeter water and apply for 30 seconds. You can increase your 20 centimeter water, apply for 20 seconds, and see how the oxygenation improves.
Because manually, we think that by pushing more air, we are going to increase the saturation. In fact, it can cause more damage to the other lung, can cause pneumothorax in the other one, cause reversal. So it is just because we are all trained like that. Whenever there is hypoxia, when the machine is there, we just keep on pushing, close the valve, keep pushing.
That's what the most of the
that it is going to increase the saturation.
Recommended tidal volume is 5 to 6 ml. Recommended tidal volume is also 5 to 6 ml. Low tidal volume.
Yes, sir.
Sir, is there any advice for the pediatric probes?
Hockey stick probe is the one which is, I think...
that is the one probe, or any other probes?
No, only that is the... Sir, that is more expensive than regular... so, now with AI coming in, I don't know whether GE people have put in, cardless probes are coming. You can set in this thing. You want vascular, it will show only vascular marking. Nerves. So just put it. Maybe in next 5 years, when somebody is talking in any of the conferences, I think there is no need for them to show all these figures. Just go in, identify the nurse. If you want only ulnar nerve, median nerve, or like that, and get away with it.
I think the cordless concept is already there with the butterfly. Butterfly.
Yeah, it is there. But the new generation GE which has come out, you can vessel, nerve, each you can single out and give only that to that specific area.
So this is to Dr. Suresh. So you mentioned about difference between chronological and biological age, and we have to assess the functional capacity. Other than METs, are there any other parameters during pre-anesthetic evaluation we can use it as a rule of thumb?
Not anything in particular. What we need to understand is the organs, functions will deteriorate, and then definitely the reserves are less. So you have to evaluate all the organs, and then, you can do all these bedside tests, and then, there's some scoring systems for each organ. So that is something which we need to understand, and METs will be a very good, objective evidence of getting these things done. So we need to understand there is problem with this, organ systems, and by age, definitely the reserve will be that much more less. So you got to be more cautious, and then make sure that you choose right kind of medications where you will not put down your organ systems, or make sure that this reserve is not come down. That's something which we need to understand.
Thank you.
Yeah, we'll conclude the session. Thank you, the speakers, for enlightening us about all the super specialities. Thank you.
May I request Dr. Raghavendra B.S., Dr. Raghavendra Bosle and Dr. Padmanabha Kaimer to do the honors of presenting a memento to Dr. C.R. Chandrasekhar, Dr. Suvajit Poddar and Dr. Suresh Kumar N. As a gesture of gratitude, we now invite Dr. Srinivasalu D, ISA National GC member of South Zone, to present a memento to our chairperson for expertly guiding the scientific session.